Assalamu alaikum. Today I will discuss a very important topic, which is torso trauma. Torso includes your chest cage and abdomen, upper abdomen. Torso trauma. There are 12 conditions collectively called deadly dozen. 6 must be addressed during primary survey, which are airway obstruction. That is straight away there is airway obstruction. You have first to do suction anything foreign body in the throat. You have to suck it out, and after that, if there is available of airway, you have to pass the airway to secure. Tongue is going back in the unconscious patient, so you have to pass the airway to secure his obstructive pathology. Then is the tension pneumothorax. Pneumothorax means extra air in the pleural cavity. Open pneumothorax. Open wound in the chest. How to manage the open sucking wound which can cause pneumothorax. Then is the massive hemothorax. Blood in the thoracic cavity. After that, pericardial, tamponade, fluid in the pericardial cavity compressing the heart, causing pericardial tamponade cardiogenic shock. Last but not the least is flail chest. There is a fracture of rib at 2 or more places, and there is a segment separate from the rib cage moving paradoxically with inspiration and expiration. So these are the 6 conditions which must be addressed in the primary survey. I will consider them first, and in the next video inshallah I will consider the other 6 conditions which must be addressed in the secondary survey. So the time tested in these conditions, which are very important for you, are 4. 3 I will discuss now combined. One is pericardial tamponade. The other is tension pneumothorax. The third one is massive hemothorax. The fourth one is flail chest, and then open pneumothorax. Airway obstruction is straight away. Unconscious patient, there is airway obstruction. The most common reason is tongue falling back. So you have to, first of all, you have to clear his mouth of anything foreign there. You have to do suction, and if you have available airway, you have to do jaw thrust, chin lift maneuver. It will help in, if the tongue is going back, it will help in lifting it up, and if there is available airway, you have to pass airway as per his requirement, which suits him, or the airway which suits him, you have to pass it. So that is airway obstruction is straight away, nothing to, especially you have to care for. There is head injury, you suspect there is anything in the spine, you have to secure the spine along with the airway secure. You have to immobilize the spine. Then you are suspecting fracture base of the skull, you don't have to pass the nasopharyngeal airway, it will go into the brain, or if there is a vessel which has stopped bleeding, it can restart bleeding. So you must be careful in the management. And then we are coming to our topic, pericardial tamponade and tension pneumothorax. Its presentation is the same in a sense that in both these conditions there will be distended neck veins, but in mesohemothorax there will be flat neck veins, distended neck veins, flat neck veins. Why? There is a overall back pressure on the neck veins which has caused them distended neck veins. In pericardial tamponade, you have to search for Beck's triad. In tension pneumothorax, there will be hypotension, unresponsive to resuscitation, hypotension unresponsive to resuscitation, but in tension pneumothorax, there will be decreased breath sounds. On the affected side, there will be decreased breath sounds, hyperresonance of that side, as there will be air, there will be hyperresonance. When you do X-ray, there will be deviation of the trachea to the opposite side, total collapse of the lung on the affected side. Distended neck veins, hypotension, and decreased breath sound on an affected side, hyperresonance on that side. So that will guide you where you have to pass the needle thoracentesis for the management of the patient to relieve his pneumothorax, that helps in response to the fluid resuscitation. Beck's triad. The main difference will be there will be normal breath sounds. Normal. There will be decreased breath sound. There will be normal. Hypotension in both conditions. Hypotension in both conditions. So what is Beck's triad? Beck's triad is muffled heart sound. There will be fluid in the pericardial cavity. It will be compressing heart. So there will be muffled heart sound. Then jugular vein distended, neck veins distended, and there will be hypotension, as I already told, hypotension. You do ECG, you will get pulses alternans. Pulses alternans. CVP will be raised when passing, and for the detection of the pericardial fluid you have to do E-fast, extended fast. It is also asked in the talk station. What is E-fast? Fast is you are searching for the four areas. So you have to do E-fast for the detection of fluid in the pericardial cavity. On X-ray, there will be the enlarged heart shadow. Nothing more but enlarged heart shadow. There will be on intention pneumothorax, there will be tachypnea, increased restlessness, distended neck will also be there, hyperogen tracheal deviation, as I already told you about. Massive hemothorax, there will be flat neck pains, breath sounds will be decreased, but it will be dull to percussion. Dull to percussion on the affected side, dull to percussion, breath sound will be absent, not decreased, breath sound will be absent, and there will be flat neck pains. Flat neck pains, breath sound will be absent, and dull to percussion will be there. These are very, very important Toacs stations: pericardial tamponade, tension pneumothorax, massive hemothorax, as well as flare chest. Flare chest, what is flare chest? Two ribs fractured at two places minimum. It can be more than that, but two places. There is paradoxal segment. There is a segment, paradoxal movement of segment of ribs, segment moving separate. It during inspiration is as cavity is going out, going in, it will move out. During expiration, cavity is going out, it will move in. Paradoxal movement. Inspiration in, expiration out. Okay. Flare chest. The most important thing which must be considered in flare chest is whether there is respiratory failure. Type 2 respiratory failure happens due to retention of the carbon dioxide. Type 2 respiratory failure occurs in the flare chest. You have to look for, and if there is type 2 respiratory failure in flare chest, you have to put the patient on ventilator. Otherwise, management is simple: painkiller, intercostal nerve block, pleural analgesia, all these things. You don't have to put the patient, you have to just to observe the patient. If there is a pulmonary contusion, patient is going to type 2 respiratory failure, you have to put the patient on ventilator. That is all about the flare chest. I have discussed you briefly about. In the next videos I can go into detail, but so far it is sufficient. Management of these two conditions, tension pneumothorax and massive hemothorax, is in tension pneumothorax, the first immediate step you have to do is to pass needle thoracocentesis in the second intercostal space on the affected side. It will give temporary relief, pressure on the heart, patient will respond to resuscitation to fluids, his blood pressure will relieve. You will buy time for more definitive management. The first step is needle thoracocentesis, and the definitive treatment for tension pneumothorax is intubation, chest intubation in the fifth intercostal space in triangle of safety. I will discuss it now in a while, but you have to first clarify your mind. The first step after diagnosis of tension pneumothorax is a clinical diagnosis. You don't need a radiology. You are suspected decreased airway entry, pass needle thoracocentesis. You can attach it with a drip, so it can behave like a water seal, underwater seal, or you can also attach it with a three-way to suck air out. You will, by time, you will make arrangement for the chest tube intubation in the triangle of safety. What is triangle of safety? It is pectoralis major, lateral border of the pectoralis major, nipple line is a horizontal line passing through the nipple, is its lower border, base of the axilla is its upper border, and the edge of the latissimus dorsi. So there is a less muscle bulk here. You can easily go through. You have to make arrangement like consent. 12 blade is needed. Just a tube of 28 to 32 French size. In the female 28 is sufficient, but in the male 28 to 32. In children less than that. Um, and 36 for hemothorax for your empyema is needed. So all these things are very important. You must consider. You have to anesthetize, give incision of 4 centimeter here, horizontal incision. You have to go through, make a space with the help of instrument, going deep, anesthetizing the space, going inside. There, at reaching the lung, you have to feel with your finger, target the track, feel all around, anything there. You have to break the adhesions and then pass the fenestrated end inside, and you have to measure how much you have to go inside, then secure the attach it with clamp it, attach it the underwater seal, put saline in the that underwater in the chamber, and you have to look for normal tiddling. Normal tiddling is movement of water column with normal respiration. There must be no air bubble. You have to secure it with the stay sutures and press it, apply the thing. These are the methods you have to follow when you are doing chest intubation. They are a treatment for hemothorax. Is you put a chest tube, and there is more than 1000 or 100 to 200 ml of frank blood coming per hour. These are indication for emergency thoracotomy. You have to go for emergency thoracotomy. So the management of tension pneumothorax and mesohemothorax is chest intubation. It is almost the same. Pericardial tamponade, its management is a little different. We go into detail. First is needle pericardiocentesis under ECG control, under ultrasound guidance. You have to subdivide area. You have to go and do needle pericardiocentesis. After getting some time relieving pressure on the heart, what you will do is you have two options. Patient is stable, straight away go to for sternotomy, repair of the damage to the heart. Sternotomy is the option. Patient is stable, then you have to go for sternotomy. If patient is not stable, you have by time straight away go to left anterior lateral thoracotomy and do emergency room thoracotomy. This is the management option for in unstable patient. In stable patient, you can do median sternotomy in operation theater. In unstable patient, you have to do left anterior lateral thoracotomy. Okay. So pericardial tamponade, I have discussed all things about tension pneumothorax, how you will go, how you will do chest intubation. Regarding the device of chest intubation, there are 3 chambers in it. One is draining chamber, one is suction control chamber, and third is I forgot the name. Is water seal chamber. These are the 3 chambers which are there. One is a drainage chamber, and the water seal chamber, and third is suction control chamber, which can be dry or wet. These are the important things which you must know. So I have discussed flange chest, I have discussed mesohemothorax, tension pneumothorax, pericardial tamponade. Airways obstruction is straightforward. I have discussed open. The last but not the least is the Open pneumothorax. What you will do in open pneumothorax? Suppose there is a that is thoracic cavity. There is an open wound here. So what you will do? You will look for offsite. You have to apply plastic. If there is no offsite, any plastic, and you have to occlude its three sides, securing it with a tape, leaving one side here. So it will help in sucking out the air but will not let the air inside. So this is the method of managing an open pneumothorax. Open pneumothorax. Three side occlusion. 1, 2, 3. And the definitive management will be chest intubation, not related to that site, using another fifth intercostal space above the rib. You have to go in the intercostal space and you have to do chest intubation. Is the definitive management. First step is the applying occlusio transparent three-sided dressing. I hope I have make you understand about the dorsal trauma and the conditions which must be addressed in the primary survey. Inshallah, in the next video I will discuss the secondary survey conditions which must be addressed. And then thanks for watching, and please like and subscribe my channel. Thank you. Bye.